Hi, my name is Greg Whitcomb, and I'm a chiropractor and assistant professor at the Medical College of Wisconsin, where I work in an integrated spine program with surgeons and physical therapists, non-operative spine specialists, medical physicians, PM&R doctors. And I'm here today with a colleague of mine, Ryan Tozel, who's a physical therapist by training. And we're going to just chat about this whole concept of timing and integration of physical therapy and chiropractic treatment in the context of evidence-based integrated spine care. And we both have a lot of experience doing that over the years.
I would like to think so, yeah.
Yeah, and we both had the opportunity to work with members of the other disciplines. So I've worked with physical therapists, you've worked with chiropractors.
Chiropractors, yep, spine
and
surgeons.
We both share some procedures and treatments in common, but I think there's some fundamental differences that are really important for people to understand as we move into a sort of an evolving age of spine care. The American Academy of Family Practice just came out with an updated guideline for 2017, and there's really a sort of a pivot shift now toward non-pharmacological based spine care, especially in the front end. So I think there's a growing interest in this topic among all spine care providers, including nurses and people of that kind of training. So just from your experience, Ryan, this whole idea of manual treatment for spine versus rehab for spine, how do we time it? How do we coordinate it? What do you think?
As a therapist, I always start out with movement. My assessment is based off of movement. I will use manual techniques in order to assess, to determine effect. So, and I'm paying attention to, and since I'm a McKenzie trained clinician, I pay attention to things like peripheralization of symptoms, centralization of symptoms, changes in even neurological signs like reflexes and strength, ranges of motion, but primarily the big ones are location of pain, range of motion. I have been able to change reflexes and strength within one session. Within just like even 5 minutes, I was able to change it.
So people with a neurological deficit, for example, if we start to use sort of positional pain relief techniques and positional pain control techniques, you'll also see a change in their neurological status sometimes.
Exactly. Yeah, and we're paying attention to, it's more than just, positional pain relief. It's actual symptom responses. So changes in location of pain, and it's not just, we're not necessarily relieving their pain, but we're changing it because we're actually creating more pain in one location. Let's say we're taking it out of their leg, but giving them more back pain. So that's not necessarily relief even in their eyes, and that's one thing that we have to make very clear to the patient is that when we do this particular technique, you may hurt worse in your back, but less in your leg, and that's actually a good thing. And I might need to use...
I mean, ultimately, right, the idea is that they're going to feel well.
Yes.
On a more sustained basis.
Yep. And
that they're going to be in a position where they have some sense of self-control, right? A lot
Absolutely.
of my patients are coming in feeling very much out of control, very sort of dependent on other treatments, sometimes opioids and other things that are high risk. And how do we get the patient feeling a little bit more confident that they have some degree of autonomy and control, putting themselves in a position where they have or are feeling empowered about how to manage their pain.
Sure.
And these techniques that you're teaching are central to that.
Exactly, yeah, and teach them how to take control, show them that they can actually affect their pain, right? Because nobody's really shown them that they can change their pain on their own by doing something very simple. We can bring them in and say, do this particular movement, and then all of a sudden their pain changes in some way, and then we go back and check one of their baselines, and when they check their baseline, they're like, this is different. I can bend forward much farther or with less pain. And then even with one of the neurological baselines that we would check, I would say, well, let's check this out again. And it changes just like that. But back to the original question of manual application of manual pressure, that's part of the assessment method to be able to say, well, let's apply more pressure. So then we'll apply manual overpressures into this particular directional preference, whatever they're displaying, and then go back and recheck their baselines again. And if they say, hey, look, then I don't want to interrupt you, but it's important to know that it's used throughout, right? It's used as part of the assessment method, but it's also part of the treatment. And it's here and there and everywhere throughout the whole thing.
That's a little variation on, a little different than what we do at our center. Yeah. But I think one of the distinctions that is important, I think, to make to patients is that this business of treatment dependency versus self-management, or the ability to have some degree of control over your pain and a little bit more confident about getting moving again, getting active again, that hurt doesn't always equal harm.
Correct.
And that you have the confidence to begin to move, and that you have some tools that if you do move and you start to have pain, that you can start to control that pain. So, one of the things I stress to patients in the context of manual treatment, because there's pretty good evidence, or at least a large volume of evidence, that manual treatment is positive in the short term, especially for acute manifestations of chronic back pain, that we can sort of bend the curve.
Yep.
But treatment is really something we do to patients, right?
Right.
As opposed to exercise or some of the techniques that you're talking about is something that patients can do for themselves.
Right. Active versus passive.
Active versus passive, absolutely. Yep. So, patients come in and they feel out of control, they feel passive and dependent, and they're afraid to move sometimes because they've been told that they've got a degenerative disc on an MRI, and oh my God, what's going to happen to me if I move the wrong way? So we have to sort of deal with that fear of movement on the front end, start to get them to be willing to mobilize, and help them to understand that there's sort of a relationship between how you move and how you feel, right?
Yes.
And there are a lot of other emerging approaches, sort of from a manual therapy and exercise-based approach, that from a neuromotor control standpoint of getting people moving again. And we know that that's also associated, right, with minimizing disability. So the sooner we get people up and moving and in a sort of a sense of control of their problem, the less likely they are to progress to disability.
The better their outcome in general.
Absolutely. So in our center, we emphasize those types of messages. And draw a distinction between treatment and exercise or self-care, and that treatment really is there to subserve that transition. So that if we give you an injection, or you have manual treatment, or you take a certain medication, that this is something that we expect to be positive for a while, and that's consistent with research, right? We know that we can bend the curve temporarily with things that we do to patients, as opposed to exercise, which may take a little bit longer to start to.
It gives the long-term effects. It's like if we just step back and say, manual medicine produces the short term, and then exercise produces the long term, and you have to combine the two.
Correct.
Yeah.
And that treatment really is there to subserve that transition for patients, and that we're going to get out of the way as soon as possible as providers, so that it doesn't become sort of an exercise in self-relevancy, that we've got to have patients coming back and back and back for treatment, and we're going to try this and we're going to try that injection, and that's when we start to see this sort of shift in focus to the provider being in charge of the back pain episode rather than ultimately the patient who has to learn to live with it, right?
Exactly. Do you find that you're using manual then as a means to move on to the active?
Absolutely.
Yeah.
Yeah. I mean, we know that early mobilization or reduction in painful stiffness allows for more rapid or effective progression with exercise. And fundamentally addressing those mechanical deficits that the person comes in with. And then there's also some evidence now coming out that with manual treatment, there's sort of a neurological reset, or there's some increased interest in this possibility that when we do some manual treatment, that we kind of affect a neuromotor change. There's a little window there through which we can now create or facilitate a change in how the patient's moving in order to get them out of a hyperlordotic posture or a posterior pelvic position, or some of these things that they can kind of get the feel, grab onto it, and start to understand what good stabilization mechanics
Kind of like a window of opportunity to let them move a little easier with less pain or something.